Hello, welcome. Welcome to the second webinar in the Cinderella webinar series dedicated to patient engagement and shared decision making in breast cancer. I'm Oriana Ciani and I will be the moderator for this session. So let's start with a brief introduction on the high-level concept that we are going to touch during this seminar. And these are patient engagement, patient centricity, and shared decision making. So the literature tells us that by patient engagement, we mean an active collaboration of patients, their families, their representatives at different levels in the healthcare system, from the micro level of direct care, clinical encounters, to organizational governance or service design, up to the macro level of policy choices. And this involvement can be a different level of intensity, from consultation up to partnership and even shared leadership. And some contextual factors might influence the outcome of these approaches. For instance, the health literacy and patients' perceptions about their roles in the system, organizational culture and practices, or societal norms, regulation and policies in place. However, involving the patient in service design and in choices increases the likelihood of make these services oriented to their needs, and this is certainly one of the pillars of what we call nowadays patient centricity or patient-centered care. And also we know from the studies that patient-centered care is able to increase patient safety, improve patient outcomes, and to a certain extent also control cost. In the same context, we might introduce the element of shared decision making, which is one aspect of patient engagement. And shared decision making means openly involving the patient in the diagnostic and treatment pathway, taking into account the context within which the choices are made in order to come to the best options that aligns with the patient's unique set of values and preferences. And one of the tools to implement shared decision making is through decision supports of patient decision aids that can be used by the patients or by the patients and the healthcare professionals together. And these tools helps clarifying the pros and cons of each choice, and also illustrate what are the best options that aligned with the patient's view. Patient decision aids have evolved over time from simple, paper-based tool to more complex digital solutions nowadays. And we even have some standards that help us identify quality tools and evidence-based rules that guide, developers and researchers in the design and implementation of this approach. So after this very brief introduction, I'm going to open the panel now with our three distinguished speakers, Ms. Marzia Zambon, a patient advocate, Dr. Miriam Knoll, a radiation oncologist, and Dr. Pawel Kabata, a breast surgeon, and they will bring us their perspective from their distinctive points of view about patient engagement and shared decision making in breast cancer. I will thank you for being here today, for joining us today, and I will invite you to follow us on the Cinderella website or social media. And just wanted to remind you to please include your comments or questions in the chat, because we will pick up on them after the three presentations. Thank you all for being here today, and Marzia, please, the floor is yours.
Thank you. Thank you all for being here. Thank you for inviting me. I would like to shortly, here I have the command. Why is it not answering? Oh, sorry, Doc, it's not going forward, or do I have the command? Control. Okay, okay, here we go. So, sorry. Let me introduce shortly Europa Donna. It's the European Breast Cancer Coalition. We are broadly recognized as Europa Donna's breast cancer advocacy organization and the oldest patient organization in the continent. We were founded by Umberto Veronesi, a great surgeon, but mainly a scientist who devoted his life to improving breast cancer treatment and quality of life for patients, and a pioneer of breast conserving surgery in early breast cancer as a viable alternative to radical mastectomy that was the standard of care at the time, developing the technique of quadrantectomy. Okay, so we then grew to become the biggest patient organization in Europe and currently comprise 47 countries, 27 are EU and 20 outside of the EU. Each of these countries are represented by a national Europa Donna organization active on the territory. And we are a women's organization. And perhaps at the time, in 1994, it was necessary to make the statement to ensure that a patient organization founded by doctors needed to create a distance from them in a world and time when professionals treating breast cancer were predominantly men. No, very few women were sitting in the decision-making steering wheel. And as we know, breast cancer hits women versus men 99% of the cases. So it was necessary to create distance and make a clear statement that the Europa Donna wanted to represent the interests of breast cancer patients and their rights to be included in the decisions and to be informed about the options which could decide about their future. These are the four pillars of Europa Donna's activities throughout these years. We actively engaged in health policy, working to represent and protect the rights of people living after a breast cancer diagnosis at a national and international level, and in our case, mainly EU level. We made it our mission to make sure that independent, trustworthy, and updated information was available to people diagnosed with breast cancer in a language that they could understand, so that they could rely on a source of information and be in a position to have some kind of say in their treatment if there was an option or if there was disease progression. With training courses and conferences, we made sure that formed and informed advocates represented the rights of breast cancer patients throughout Europe and spoke on their behalf and on behalf of people living in the same condition. So here we are, 30 years of advocacy this year, and I think we did quite a great job. The main challenge to be truly effective was to create a close network and a team to work with. Policymakers, researchers, healthcare providers, industry, civil society, and at a national level, administrators, payers, and everyone who can make a difference and should be included in the circle of a prospective change. And you see, one of the four main pillars is being included and participating in research. Ever since 1994, we aim to engage directly with researchers to make sure that clinical trials were accessible and representative, but especially that the questions asked in clinical trial were really relevant to patients and truly meaningful for the breast cancer community. Now, almost all patient organizations considered being involved in research as a must or a given. It really was and is not. It is only in recent years that FDA and EMA have made the inclusion of patients' voice in research a nice to have or even a requirement. And patient-reported outcomes and quality of life beyond treatment are now a benchmark and sometimes even a formal endpoint of the trial. So this is a list of the research projects that we are currently involved at Europa Donna actively. We are work package leaders in one of these Horizon projects. And as you can see, Cinderella is circled there. And we are extremely happy. I think the circle went on outside, but it was actually aimed for Cinderella. And we are so proud to have been asked to participate in this project. Okay. So what is the turning point in breast cancer advocacy in 2024, and what has it been in the last years? Europa Donna started advocating for population-based screening programs. Much is still to be done, but the OECD report that was issued in February 2024 shows that vast majority of EU countries have now put in place very effective breast cancer screening programs. We still have much to advocate for regarding actual participation, but look at the avoided deaths. From 1990 to 2020, 475,000 deaths were avoided overall in the EU and 32,500 in 2020 only. And let's look at the advancement in treatment. I borrowed this slide from Professor Peel Haar of Karolinska Institute. He gave a fantastic presentation at the Breast Cancer Nordic Conference this past September in Copenhagen. And it shows how advancement in treatments made a huge difference in breast cancer survival rates. The slide shows the impact of Herceptin in the second half of the year 2000 decade. And many more incredible drugs are being developed, which can truly change the life expectancy following a breast cancer diagnosis. So here we are with the current numbers in the United States. The American Society, the American Cancer Society indicates that for breast cancer, the 10-year relative survival rate is 84%, and the 15-year survival rate is 80%. In Europe, we finally have the ECIBC, that's European Commission Initiative on Breast Cancer Guidelines. Europa Donna actually cooperates on the working group for the development of these guidelines and for screening, diagnosis, and early detection of breast cancer. And they are regularly updated and open source on the Commission and on the Joint Research Center website. And as for treatment, the final version of the quality assurance scheme and the manual for breast cancer services is going to come live by the end of this year. So this is very good news. The concept of a specialized breast unit or breast cancer service, as called in the guidelines, with a multidisciplinary team around the patient and including the patient, is now close to reality. In specialized breast cancer units, patients not only contribute, but they are encouraged to voice their preference every step of the way, with a true strive toward a shared decision-making process each step of the cancer care pathway. Options are explained and a holistic approach is promoted. This is where everybody is aiming to. On the other hand, we still have some resistance. So what if the preference expressed by the patient is not, according to the professional, in her true interest? Who knows better? How can we take into account all variables and ensure that we are actually doing the best for the patient's life? What is the best result? Overall survival, quality of life, These are questions that have started to surface. And this happened thanks to the very good median survival rates and numbers that I showed before. So what is quality of life? This is how we have started to change some of our priorities as breast cancer advocates. Quality of life has become important. Life after surgery and after treatment and survivorship are becoming increasingly important. So now that more and more breast cancer patients survive a diagnosis for a longer period of time, how they survive, and if they go back to work, if they manage to manage the side effects and the emotional and physical side effects, their social and family life, their sexual well-being, their fertility or fertility preservation during the treatment after breast cancer surgery, and of course, their self-appreciation. So, how will I look? How will I feel? How will I feel about myself? How will I be seen by others, nude or in a bathing suit, by my significant other or life companion? And how can I face starting a new relationship after breast cancer? All side effects considered, self-image and reassurance in one's comfort with one's body is a very powerful side effect to deal with. And this is why it was so easy for us to embrace Cinderella. And this is what it means. How will I look? It's no longer a Barbie question. It is perfectly reasonable to want to know how you can expect to look like after breast cancer surgery and radiation treatment. And we trust that by the end of this clinical trial, we will have a great tool to help women visualize their body and their image after surgery and treatment. The aesthetic result is a very important piece of the puzzle, and it was a taboo until now, and it should no longer go underestimated. Thank you.
Thank you, Marzia, for this presentation. I remind everyone to include the questions and feedback in the chat, and I will leave the floor now to Dr. Knoll. Thank you.
Hi, everyone, joining you from New York. Thank you so much, Dr. Ciani, Dr. Orvi Darperson, Cinderella Project, and the organizers for inviting me to speak today. So I'm going to be talking about supporting patients through shared decision-making and use of decision aids in oncology. These are my disclosures. So in the next 10 minutes, what I want to cover is how information and misinformation is rampant, how patients are utilizing digital tools, why harnessing these tools is essential, and how shared decision-making is vital to improving care and empower patients, as we saw from Marzia's fantastic presentation. So we all know that as physicians, it's not just us in the room anymore. The patient's iPhone is there 24/7. And in fact, that search for knowledge happens in a 24/7 basis, not just when we're seeing patients, but when they leave our offices as well. A great example of how social media has transformed information sharing was during the Miracle on the Hudson, when somebody who was actually watching what was happening with the plane in the Hudson said, "I'm going right now," meaning at that moment, what people learned was that they can share information in an immediate basis. So we all know that social media is used at increasing rates for all different age groups and all different platforms. And what information is being shared includes clinical trials for enrollment, including advertising on social media for clinical trial enrollment, discussions on social media platforms such as the curated discussions such as LCSM chat, BCSM chat. BCSM stands for Breast Cancer Social Media, which happens on X, formerly known as Twitter. And what I love to share about this one specific example is that the conversations that are happening are an extremely, extremely high level. And these individuals that are responding to these questions about, for example, here, lung cancer, but also similarly for breast cancer, these are patients, these are not physicians. And yet the conversations they are having and the amount of content that they are distributing and sharing with other patients and patient advocates is absolutely unprecedented. Advocacy is not new. In the 1990s in the United States, due to advocacy by a patient who was 35 years old, whose insurance was not going to cover breast reconstruction, her advocacy together with the New York State Senator led to insurance now being required in the United States to cover reconstruction. Again, this is something that we could not imagine even being fathomable, that breast cancer reconstruction wouldn't be covered. And yet it was only covered because of patient advocacy. And similar patient advocacy has led to other laws, including dense breast notifications for women who have dense breasts and require a sonogram in addition to mammogram, increased funding for research for studied, in their opinion, for patients with lung cancer and other types of cancers that get less funding as compared to others, and including even advocating to change national guidelines, for example, NCCN guidelines. In this case, a patient who at that time, a couple of years ago, would not have been offered consolidative radiation or consolidated treatment due to stage 4 disease, actually advocated to have NCCN guidelines change because discussions that she was having with her physicians was not reflected in national guidelines. So again, the patients are having these conversations, and I think the challenge is really, how do we as physicians engage in those discussions that patients are already having? So what we know is that we have discussions with our patients, but what other conversations are they having on their own? And how do we bring those two together in a more efficacious way? Here's just one example. Let's say a patient wants to enroll in a clinical trial. So they go to clinicaltrials.gov. This is a website in the United States, and they search breast cancer. Well, how are they going to find a trial? When I first started looking into this, well, over 9,000 studies came up. Guess what? A month ago, we're now up to over 14,000 studies. So how is a patient who is looking for a fantastic information, or maybe forgot to have a discussion with their physician when they saw them because they were overwhelmed, is now going to search through over 14,000 studies? So we have a phenomenon of patient-centered research, not just in breast cancer, not just in cancer, but in all different kinds of diseases, that is leading to patients saying, I want to do research, I want to be a part of research, and creating spaces and discussions that previously never existed, utilizing digital tools. So what digital tools now represent, it's not just Instagram, it's not just Twitter, it's not just Snapchat, things that we think of as what kids use to sort of promote themselves and be influencers, but actually as ways of sharing information, as we just saw with the Cinderella project, utilizing digital tools to really harness and have these conversations in a more effective way. Another example of patient-initiated research is Count Me In. This is run by Dana-Farber with partners, where individuals can actually upload and request their own slides, their own pathology directly into this study that is decentralized, so patients can participate from anywhere as long as they can actually get their slides directly to researchers. So back to decision support tools and decision-making tools such as Cinderella project, which is an unbelievable project, and really excited to watch it unfold over the next couple of years. Comet is an example of a DCIS decision support tool that's based at Duke University. And basically this website, if you go to it, it's literally unbelievable way of sharing information with patients about their DCIS options and tools, and patients can actually click through and say, this applies to me, this applies to me, this applies to me. Okay, here are my options. And what I love about this website too is that it also shares that, well, active surveillance is not an option for DCIS in the standard of care, but if you're interested in it, look at this trial that's open, you can potentially participate in it. So it's not only helping patients understand what options are open to them, but also encouraging them, if they're interested, to participate in a clinical trial. Evidentio is a similar decision support tool based in the Netherlands that is also helping women with breast cancer understand and decide what their risk of local, regional recurrences and second primary tumors. And studies have shown that utilizing this tool really leads to improved and increased shared decision making for patients and increased confidence in these decisions. And just as an example of what it means for shared decision making, the tools that are used to measure these outcomes are very specific. Things such as, my doctor made clear that a decision needs to be made. How much effort was made to help you understand your health issues? Do you know which options are available to you? So when patients answer these questions at higher rates, we understand that their knowledge and their agency in those decisions is significantly improved. So what we've learned today, in short, is that yes, information and misinformation is rampant. We know that individuals, that patients are utilizing digital tools. They're having these conversations across many different digital platforms and social media. Harnessing these tools is really, really important, and utilizing them in a shared decision-making space is a way to harness these tools for better patient outcomes. Here's my contact. I would love to hear from you. Thank you again for inviting me to speak.
Thank you, Dr. Knoll. Really fascinating to hear about those different tools available around the globe. I will now leave the floor to Dr. Kabata, who will specifically present the Cinderella approach and the underlying shared decision-making tool that we are testing in this trial. Please, Pawel.
So good afternoon. I'm one of the investigators. I'm one of the clinical investigators in the Cinderella approach. So what I would like to show you is to actually try to convince you that this approach is really useful for us surgeons. So we all know, as we already heard, that breast conservation and breast reconstruction are actually right now the methods of choice for treatment of breast cancer. This is the standard of care. So whenever possible, our goal is to save the breast or to make or to reconstruct the breast if we need to perform the mastectomy. And this is mainly caused not only for better aesthetic outcome, but also for better functional outcome. And of course, this causes lesser body image related trauma to the patients, as it was in case of just a classic radical mastectomy. And currently, we're in the, as Marzia said, we're at the level where through the last 40 years, the techniques of surgical treatment of breast cancer have developed incredibly. We have ton of different techniques of breast conservation. We have different techniques for breast reconstruction with implants, with patient's own tissue. We can move flaps from different or remote sites of the patient's body just to reconstruct the breast. And even though we have so many tools in our hands, so theoretically we should be able to choose a perfect option for each patient. But apparently, still 30% of the patients who will undergo radical breast cancer surgery will have a poor clinical, aesthetic and clinical outcome. So the reasons for this are few. So one of the reasons that have to be mentioned are the tumor-related factors. So for instance, the localization of the tumor within the breast. We have different parts of the breast where the amount of the breast tissue is different. And depending on the placement of the localization of the tumor, the technical difficulties that we as surgeons meet are very different and might influence the final aesthetic effect. Then we have the size of the tumor and something we call the breast to tumor ratio. So it means how big the tumor actually is for the breast, because a 2 centimeter tumor will be different in a A-cup breast and will be much different in an ECAP breast. So there are also patient-related factors adding to this aesthetic outcomes. So first we have the breast size. Then we have the quality of the tissue, so the breast density, the quality of the tissues that we are actually working with, and of course different patients' comorbidities, which might influence and sometimes prevent us from having or proposing the patient different treatment options. And then, of course, we have to mention that we have also treatment-related factors. So the one that has to be mentioned is the incorrect qualification and poor quality of the surgery that the patient gets. Then, of course, we have to keep in mind that there's a certain amount of complications that will be connected with each type of surgery. And of course, we have radiotherapy, which can destroy even the best aesthetic outcome just because of its biological function and and what it does to the patient's tissues. So we really try to explain the patients what our expectations are as surgeons, depending on the quality, on the size of the excision, of the amount of excised tissue, on the location of the tumor, and we really try to explain it to the patients and to try to show them how this breast might look. But sometimes, especially in reconstructive surgery, the amount of changes of the redesigning of the breast, reshaping of the breast is so advanced that even non-surgical doctors have problems understanding what actually will be done. So we know that the first thing that the patients will do is to search the web, as Miriam said. So they will search the web, they will search the social media, and most probably they will find the wrong answer because they will find a picture of a patient of a completely different type of a completely different size, of a completely different type of tissue, type of the tumor. So most probably the patient will get the wrong answer for the question, how will I look after the surgery? Sometimes they may ask the friends or other people in their environment who underwent surgery. But again, this is the same bias that they will come. So they will ask different patients with different weight, different kind of body shape, different kind of breast, which will again cause some confusion. And this is where our Cinderella approach and the Cinderella app comes in very, very handy. And just a disclaimer, this Cinderella app is downloadable from the App Store and the Google Store. However, please keep in mind that even if you download the app, you will not be able to get into the app because this app, the login details are given only to our patients. So of course, patients are invited to join the app in one of the 6 trial sites. But if you download the app from any of the stores, you just won't be able to get in. But anyway, I will show you how it works. So the first question that we have and the information that we have about the patient, so we feed the algorithm, the artificial intelligence algorithm, with the patient's details, so with patient's weight, with the patient's height, with the patient's cup, of the cup size. So the algorithm knows much more. The algorithm again gets the actual pictures of the patient's body, which is contoured by the surgeons so that it can pick the most crucial parts, and it can pick the size or calculate the size and the parameters of the breast. And then basing on this algorithm proposes us with a number of pictures of the patients that have already been operated. So for instance, if I speak with the patient, if I tell the patients that after this surgery, she might expect a slight reduction in the size of the breast, or that the breast might be uplifted afterwards because of the amount of the tumor of the tissue excised, I can actually show her what it really means. I can show her on live pictures what's the difference between the breast, how this smaller breast looks afterwards compared to the one that has not been operated. Then again, I can show the patient, because the pictures have been censored by the surgeons, so I can show the patient what from our surgical perspective, what it means that the end result is excellent, or what it means that it's just regular, that it's something that occurs and it's nothing wrong if this kind of reduction in the breast and the change in the breast shape appears. So this is incredibly helpful for the patient and for us. And then once we choose the pictures that we want to show the patient, the patient can see the pictures anytime, any number of times she wants at home, because she has all of them in the app. She has a tailored video to see, explaining the principles of the surgery, and she can read a lot of professionally provided knowledge about the surgical procedure, and she can also decide how much information she wants to get, whether she wants to get just very basic information about the surgery, or she wants to have it all, including the most common complications with their frequencies and the chance of occurring. So the natural question that comes in mind is, of course, okay, if we have the plastic surgeons, if they have already existing tools to show the patients, for instance, in breast augmentation, how they will look, what will be the effect of inserting the implant, of augmenting the breast with implant, why don't we use this kind of tools? The problem is that with plastic surgery, we basically either reshape the breast or just make it bigger. We don't remove any tissues. And with cancer surgery, we remove a certain amount of breast tissue and then do whatever can be done and do our best to make this breast look as good as it was before, to make it look as satisfactory for the patient as it can be. But it's not plastic surgery. It's cancer first, and then aesthetic surgery comes after the cancer treatment. So this is why we are not able to use and utilize the commercially available tools for plastic surgery. So just to conclude, our goal as surgeon and as patients is to treat the patient efficiently within the oncological rules, but also to make it aesthetically acceptable for both sides. But to have it, we just need to have a plan, and part of the plan, it's not only surgical plan, but we also have to prepare the patient's expectation for the possible coming effects, because without it, we can just wish about meeting somewhere in the middle between our chances, our possibilities, and the patient's expectations. So thank you very much.
Thank you, Pawel, for your nice presentation around the Cinderella approach. I will now open the floor to questions, and actually I've seen already one in the chat, which I'm going to ask to the panel. So as a physician, you encounter patients who want to know less or more. How do you approach this at clinics, especially with patients who don't want any information? And I guess this is mainly for the doctors in the panel.
So I am very straightforward myself. So I always have the same standard routine of telling the patient about the surgery, and I always I make a lot of drawings actually on the patients, because this is the best the best option, because she can actually see it when she goes home. She can see it without this stress of being at the clinic, being in front of the doctor. She can just take a look at it. And we had situations that the patient said, okay, you know what? I don't want it. I want something different. So then she came back to us and we decided on a different approach. But I always try to use as much time as possible and as much time as the patient needs, because there are some patients that say, okay, whatever you do, just do it. I'm all yours, just in your hands. And I don't fight with them. I'm not, taking my shovel, and I don't overwhelm her with the amount of knowledge that she doesn't want to know, because she won't listen either way. So I'm more proactive, and I try to fit in to the patient's expectations and the patient's needs. However, sometimes patients can sit over an hour. I just recently I had a patient who I spoke about breast conserving surgery for an hour because she had so many questions. So it also happens.
Yeah, I totally agree with Dr. Kabata. I think that, it's really important to understand what the patient understands first. So, I have usually the benefit of seeing the patient last as a radiation oncologist. So they have usually had multiple discussions with multiple physicians. So I'll ask by saying, what's your understanding of what's going on with your health? What do you understand about your treatment? What have your doctors told you? And that really helps me understand what they know. And other questions such as, what questions do you have, instead of do you have questions, right? So the really targeted ways of facilitating conversations with patients. But I also agree 100% with Dr. Kabata. Like, if a patient doesn't want to have a more detailed discussion, that's their right. And if they, feel comfortable with the recommendation that has been made, then that's what we do. So it's a back and forth, and that's really what shared decision making is. Ultimately, we want the patient to have the confidence that whatever treatment they are undergoing, that they have decided on their own. And I'd love to hear Marzia's thoughts on this as well. From your patient perspective, what's the wrong way to do it? We obviously have the doctor's perspective here.
Well, thank you for this. More and more, let's say it's more of a women's thing, both to go for Dr. Google and to want to have a say in everything. More than women. I notice in breast cancer versus prostate cancer, the attitude of just get it out, I don't want to know, is more of a man's approach. As a general, very, very basic level. On the other hand, I think that it's very important to draw that line where there's informed shared decision. And I think there are a lot of devices that are being developed also in the Netherlands for shared decision making in various phases of treatment. And I think it's very important to consider the literature, the health literacy of the person, to read the person and try to give them feedback. Perhaps it would be great to have the design on your body so you can go home and look at yourself is a great idea, but also to have, look, these are reliable sources. Have a look here. This is something that you can look at. This would be great to hand out. Breast navigation, certain nurses, rather than, obviously, oncologists, surgeons, radiologists, you have limited time. And I would not want for that time to be compensated with sources that are not reliable or basically the word of mouth can be dangerous. It's very much depends on where the patient is searching. And I think that we as patient organizations, but also at a clinical level, there should be some orientation toward reliable sources to look into.
Thank you. Thank you. We have other questions in the chat. So the first question is whether there are resources for patients in languages other than English, either local website or translations of international resources. And on this question, I'm going to remind everyone that, to look at the Cinderella website and our social media, also because there will be an upload of these recordings in different languages, 6 languages at least. So watch out the space because there will be, more material coming up. And then the next question is for you, Marzia. Could breast cancer patients groups contact Europa Donna directly to get information on or support?
Yes. Okay, we have all of our resources are open source. So we have booklets and publications specific on certain topics. But we as a coalition would not have perhaps the territorial control. So what I would suggest, if it's a European patient or group, to contact the National Europa Donna organization. And there, I think it would be more specific, more territorial, and more approachable information. We were talking about language. We as a coalition, we are dealing with 47 different countries. That in Europe very often means different languages, different health systems, different a lot. So as a coalition, perhaps we would not be as useful as the let's say the local Europa Donna organization, but absolutely welcome to contact the Europa Donna local national organization.
Thank you. And then the next question is about the patient's reaction with respect to the, AI, artificial intelligence component of the Cinderella tool, or I guess any other tool. So do you think they are skeptical towards it, or do they trust these applications? So based on your experience.
This is me again. No, okay, then Pawel.
Maybe I will just very briefly tell about our real life experience with the Cinderella app. So basically, we have we have 3 groups of patients. So one are the patients who, when they hear that they have to do something within the app, they already say no. I'm not fluent in smartphones, stuff like that. They say no, they don't want to have any app. They just want to have simple things. So this is one group. The second group is a overly excited group, so that they're very excited to have something new, something very fancy with artificial intelligence, and I think their expectations are maybe sometimes even higher than we can provide them. And the third group is the patients who are, let's say, neutral. So they say, okay, it's fine. I will do this. If you want, I will take a look. It's something more. It's some information additional. So it might be helpful.
I would say my perspective is from the physician side. I think that doctors probably distrust AI more than patients do. And I think that it's really admirable that you all on the Cinderella project are really spearheading the use of AI in a way that's patient-centric and looking to improve patient care. I'm part of the leadership development program for ASCO, American Society of Clinical Oncology, and the project that we're working on is actually about AI. And what we're looking into is how do oncologists utilize AI? And what we're finding is that most oncologists really don't even know about AI. And, helping doctors learn how to utilize it in a good way and in a way that's helpful for them, helping patients, I think is really important. And I think we're just starting to learn how to do that.
Sure. And then the next question actually is linked
May I just add very fast to that?
Marzia.
Yeah, I think because we've been having a lot of conferences around AI, And I think in this case, the use of AI is, let's say, easier to accept because it gives you more options, more visibility, more understanding, more vision into the future. The distrust or potential distrust of patients toward AI, I think it's more in the diagnostics or in the imaging. That's where, Amisha, how was it fed, this information? This is where I think we need to work a little bit on the trust issue of a patient putting their hands in putting their lives in the hands of a machine.
Yes, yes, I kind of agree with that, Marzia. So the next question is actually linked with a question I had myself. And so this is about the diffusion in clinical practice of shared decision-making approaches and patient decision aids, because, you know, from the literature, we know that they are good, that they improve, you know, patient outcomes, they, you know, reduces the decisional regret, they increase adherence to treatment. So when they are tested in RCTs, these tools are in general producing good results on, you know, when meta-analyzed. However, we know that their use in clinical practice is not widespread. And so even, I mean, if I ask you what are the tools that you use in a routine practice, I would be curious to hear what they are. But then the question is, what are the barriers to the widespread adoption of these solutions in the real life?
I think that the main barrier, or maybe it's not a barrier, it's more like a warning for us and the threat, is that first of all, we know that the AI is not perfect, and it's sometimes in terms of the quality of the image, it might be even overreacting, let's say. So I think that the threat is actually what we spoke with Marzia before the webinar is, what if the final outcome, the final result is not what the AI planned? So what if the patient, so if the patient gets the picture based on like 1,000,000 of different pictures of what her breast will or should look like after the surgery, but apparently some complications came, some, I don't know, some unexpected radiotherapy complications, surgical complications, or just simple, just a worse or a much, I mean, a bit worse surgical technique, or the intraoperative complications came by, and the final result was not as planned. And I think this is the biggest threat for us, and it's a kind of a warning that we don't. I see this as a kind of barrier that we cannot say the patients that, hey, you will look like this, you might, or look alike. So this is just a presentation of what you can expect, but it's not the way you will 100% look like.
Thank you. Marzia and Miriam?
Yeah, I mean, I think the barrier is utilizing tools that we trust, right? So we know that patients are utilizing tools on their own. What we're adding to the conversation is the utilization of tools that we trust as well, as a way to facilitate the conversation. Because otherwise, what we're left with is only what patients are using, and that is certainly not what we want.
Yes,
Yeah.
Marzia?
I completely agree with Miriam. I think it should be facilitation to, you know, speak the same language and go in the same direction, shared decision making, and not speaking and expecting something that then is not. I mean, I think it's an effort both on the patient's side and on the professional side to actually try to really feel as a team working in the same direction. And that's a lot about also communication skills on both parts. So, I mean, it's people in the end. So sometimes it works, and sometimes it doesn't. But that helps and facilitates, I think it's definitely a good way to go.
Yeah, and talking about communication skills, so a question is about do you feel that tools like AI in shared decision making diminish the doctor's role or empowerment in the patient-doctor relationship, or do you see them more as a means to enhance collaboration and trust?
I'll take this one to start. I think, let's be honest, the physician's role has already been diminished, and it's not because of AI. It's because, if you think of the physician's role as the knowledge base, if that's your definition of what a physician does, then that has already been taken apart, not completely, but almost completely, because there is so much, like my slide, you can't bring your iPhone in as your primary care physician, right? So what is the purpose of a physician? That's a very good question that we need to ask ourselves. AI is a little bit more obvious in the way that perhaps it could be used because it's so fast and so easy, but ultimately that sort of degradation, if that's what we're calling it, has already happened. So I think it goes back to the more basic question of what is our role as physicians, as oncologists. And I think that hasn't changed, and it hasn't changed since time immemorial, where there were always physicians, right? Go back in history, there were always physicians, even when physicians could do nothing. We couldn't cure anyone, we could barely do surgery, we had no antibiotics, and yet as long as there was civilization, there were always physicians. So if physicians were important when we couldn't do anything to help disease, and now we can do disease, and yet why are we still needed? We're still needed because the physician-patient relationship is still really important for society. So it's a tool, again, that patients are already using, and it's our imperative to utilize it in a better way and to help guide that conversation, because otherwise physicians are going to be way in the back of the line, such as, for example, with electronic medical records, right? Electronic medical records were adopted so fast with such zeal, doctors were left sort of scrambling to figure out how to utilize these things. We can't let that happen with AI. We have to be at the forefront of adopting AI so that it's utilized in a way that we think is important, both for physicians and, more importantly, for patients.
Well, however, in surgery, I mean, I think I will. I mean, just last week I had this discussion in my family. Will you be replaced by the AI or the robots? I mean, we have like 20 years of robotic surgery, and still it's the surgeon that controls the robot. So again, well, at least in surgery, it's still the surgeon that does the surgery. Of course, AI, it's a great tool, but still, I think it's a tool, and it will be a tool for quite a long time still. So yeah, I just answered that. I think I will retire, still being a surgeon and operating actively. So.
Yes, Marzia, a comment from your
Completely,
perspective.
completely agree, and nothing can take the sense of trust and of protection that your doctor that you trust gives you, whatever machine he's using. So I agree, it's a tool, and I hope we all retire with that being still the reality.
And I tend to agree, and this reminds me about a survey we did last year. And these were mainly, Italian patients and their doctors. And the first most important element that they bring up in this survey was exactly the patient-doctor relationship and the fact that this can be, replaced by any tools, or not. We're not there yet, but certainly this was the main key message. Okay, I think we have reached the end of this second webinar. Let me thank once again the three panelists. It was really great to have this discussion with you. And I just remind everyone about the next webinar in the Cinderella webinar series. This will be about the use of AI in Cinderella with a more technical angle, because we will have in the panel the AI experts software developers and those who developed and brought the Cinderella platform to make it usable and used in the trial. So thanks again, and do not forget to follow our website and our social media. Thank you.